You cannot have a national health service, you cannot have a healthy nation if you exclude minorities from the provision of healthcare. Simple as. And therefore, I think the job is on for us to not be daunted by all the kickbacks that we're getting at the moment, but to stand our ground and say, no, it is important not just for us that we are included, it's important for other people.
Good afternoon, everybody. Welcome to the Chamber LGBT plus History Month panel. I need to get some new teeth, clearly. My name is Helen Belcher. I'm a councillor in Wiltshire, and I've been asked to chair this session. And we have some very illustrious people who I will let introduce themselves. So I'll start with Liz Barker. Liz, if you could say a couple of sentences about who you are, what you do.
Yeah, I'm Liz Barker. I am the Baroness Barker. I'm officially a lady. I'm a member of the House of Lords, and I am a member of the All Parliamentary Group on Global LGBT Rights.
Thank you. Then we have Layla McCay. Layla?
Hi there. I am the Director of Policy at the NHS Confederation, and I run our National Health and Care LGBTQ plus Leaders Network, and I'm just about to publish a book called Breaking the Rainbow Ceiling.
Excellent plug there. Well done. So we might try and remember to do that towards the end as well. And Kate Davison. Kate?
Hello, I am a lecturer in the history of sexuality at the University of Edinburgh, and I am also sometime soon about to publish a book about the history of aversion therapy. So I specialise in the history of sexology and sexual psychiatry in the 20th century.
Okay, fabulous. Thank you very much. Right, well, we're going to try and have a more of a conversation. So we've not got that many questions, but so you've got a bit of time to talk around them. So it's LGBT History Month, and this year's theme is around healthcare and medicine. So Layla, I wonder if you could start us off. What historic achievements and events which impact the LGBT plus community stand out for you? And that can be either healthcare or non-healthcare related.
Well, since you've come to me first, perhaps I should come to some of the earlier trailblazers that we've seen in the healthcare world who happen to be LGBTQ plus. And being that I'm from Scotland, I was pondering this, and I was thinking of a couple who studied medicine in Scotland, and one of them is Dr. James Barry, who is a very well-known surgeon who had all sorts of really amazing, groundbreaking work in surgery. And it was later found that Dr. James Barry had been born a woman and had worked as a surgeon all that time. As to Dr. Barry's sexual orientation, gender, we don't know the details of that, because of course at the time women were not necessarily allowed to practice in this field, but I think it's a really interesting example. And then another one that strikes me from the same sort of era, just a little bit later. So James Barry was working sort of in the late 18th, early 19th century, and Sophia Jex Blake was just after that, sort of mid-19th into the 20th century. Again, a big advocate for women's rights, a physician who founded the Edinburgh School of Medicine for Women, and very well known to be a queer woman as well. I think it's really interesting to see people who were working quite some time ago. It really grounds you in the knowledge that the history of LGBTQ plus people in medicine is not a recent one. This is a proud history, and it's nice to be able to celebrate it here.
Kate?
I mean, I think I would like to highlight a collective effort. To me, it's extremely important that we remember the work that the gay liberation movement, so I'm calling it that because I'm talking about the very, very early days, so the early 1970s. I think the gay liberation movement, because that was one of the names it adopted, and associated groups really did very, very important work to completely overturn what was then known, what has become known in the historiography as the medical model. So this is the idea that that having any kind of non-normative sexual orientation or gender identity, irrespective of which one, is a pathology. It's an illness, it's a disease, it's something to be treated, something to be cured, something that requires medical attention, something that is a problem. And I think that one of the world historic achievements of the gay liberation movement and the gay rights movement in the 1970s was really to effectively overturn that. I think, unfortunately, in more recent years, we've seen a kind of a reviving of the medical model and an application of that specifically to the trans community. And that is a development that I think everybody should be extremely concerned about, because if we think about this world historic achievement, and then it can, you know, it is possible for it to be overturned effectively for the logic and the expansive kind of victory that represented, for that to be overturned, but only for a portion of the community. So that's kind of a bittersweet victory, I suppose. But it's something that I think is really important. That's what my research focuses on. I focus on the prevalence of the medical model in the middle decades of the 20th century, and then the achievements of the gay rights and feminist movements in the 1970s in overturning that. So that's something that I'd like to trumpet as a major achievement, and we should celebrate it so that we can not repeat the mistakes of the past.
Liz?
I think it's not possible to have an event like this and not talk about HIV. I'm not one of those people who is a Pollyanna who says, oh, great things happen because of HIV. No. HIV has been a Holocaust on AIDS was a Holocaust on our community. But that said, it did mean that for the first time, gay people in numbers were visible within healthcare systems, and the healthcare systems had to begin to deal with gay people openly on their terms. And I think one of the things that I find most interesting is that I was involved in some of the very first work which was done about in Europe about older people and HIV. We did this in Age Concern. And I remember going along to the Chelsea and Westminster Hospital, where they had this, I'm going back over 30 years now, where they had this innovation. They had this suite of computer terminals where patients could go in and access the internet. And what that meant was that a group of young, educated, largely gay men were turning up to doctors really informed, but I mean, sometimes better informed than their doctors were about the latest development, and challenging the care that was given to them. And I think that and the changes that came from that. Another example would be, recently I was at, a bunch of us went back to London Lighthouse to unveil a rainbow plaque outside London Lighthouse. And the way that London Lighthouse changed nursing and care of people who were terminally ill, I think made a huge impact, not just on our community, but wider than that. So I think we were forced, for reasons that none of us would wish, into a position where we challenged the way in which health services are delivered, and began to put patients to the fore in co-designing their healthcare in a way that had not happened before.
I think what strikes me when talking to a lot of leaders within the LGBT plus communities is, for the older ones, how many of them actually suffered loss through HIV, and how much that really powers the work that they do now, and in some cases have done for decades. And I think it's, you know, the HIV thing has massive ramifications, not only for, as Liz you said, around how healthcare is delivered, but also about how, touching what Kate, you were saying, how people start to see LGBT plus people. It's interesting, Kate, that you touched on the pathologization, because as a trans woman, my understanding is that we've kind of constantly always been pathologized, really. It's been a constant battle to try and get the healthcare we need. Do you see signs that had started to change and it's now snapping back, or is it are we being a bit too negative about what's going on at the moment?
Sadly, I don't think we're being too negative. I do think that it is a cause of serious alarm. I'm not from the UK. I'm from originally from Australia, but I also lived in Germany for many years. I came to the UK two and a half years ago, and I've been truly alarmed by the atmosphere that I have found here. I do think that I think you're right to point out that there was a very short window, perhaps, where trans women in particularly trans men as well, and also trans non-binary people, you know, there was a short window where I think there was a kind of a light at the end of the tunnel. The changes that were made, for example, in 2016 to finally remove transgender identity from the World Health Organization's International Classification of Disease. I think that was a significant moment. And it really seemed as though in 2015, 2016, it really seemed as though the world was really beginning to get ready to take that next step. I think it is not using alarmist language to call what has happened in the UK in the years since a backlash. And I am deeply concerned about this. I teach about this at the university. I teach especially about the things that that Baroness Liz Barker was saying about co-designed health models. And I take a lot of my thinking around this. You know, I have a whole kind of course that I've designed for fourth year students about interactions between health professionals and LGBTQ plus communities across the 20th century. So, and it's a global course. We go from early 20th century Germany to, you know, 1920s China to, you know, Central and Eastern Europe in the 1950s. We go all over the place, and we find examples of this kind of attempt by communities from the grassroots to really sort of participate in healthcare, designing healthcare, and trying to resist the pathologization, but also at the same time trying to achieve actual healthcare for the things that they need healthcare for, which do not include sexual orientation and gender identity. But there's a slogan that is often used, and because I'm from Australia, I take a lot of advice from First Nations people in Australia. And one of the, in a previous life, I worked in the museum sector, doing a lot of kind of untangling of colonial kind of museum collections and that kind of thing. And one thing that a number of curators said to me in particular was, you know, there is a principle of nothing about us without us. And I think that this is, if there was to get to be one kind of guiding principle for policy for, you know, parliamentarians and lawmakers in the UK, I think that that would be a very, very good slogan to take on. It carries on the spirit of the what came out of the AIDS crisis, but I think it really needs to be a permanent evergreen in healthcare design, so that we can start to try and dismantle some of the backlash that has been going on in recent years.
And Layla, to sort of turn to you with your NHS Confederation hat, do you see that there's a backlash within the NHS?
Not so much within the NHS as within the backlash that we're seeing in the wider population has impact in the NHS, just as I think it has impact in all public sectors. It's interesting. We were just talking about the AIDS pandemic, and speaking to some younger staff within the NHS and health and care about that, having just come out of the COVID pandemic, they found it very hard to imagine a pandemic in which all stops were not pulled out to try to solve this and help the people who were affected. And I think that what we're seeing now is political reasons and political discourse that makes people more anxious about engaging in that way, in continuing to drive that forward. So I think it's incumbent on all of us to try and separate out the political conversations that are happening in this election year, and actually the historic progress that's being made. I think there's an assumption that we walk in a straight path towards progress. And in fact, not only is that path not straight, but it can very easily go back on itself. I think that a lot of people are worried about that. In the Health and Care Leaders Network, which includes leaders across the NHS, they tell us that they are anxious about the intersection of political rhetoric and delivering the care that people need in the NHS and supporting the staff in all their diversity across the NHS. It's a real concern, I think, for people at the moment.
Okay, thank you. Liz, you touched on the impact that HIV/AIDS had on healthcare. And I think you talked a little bit about why that was important. Are you concerned about, Layla's brought out the sort of the COVID parallels, are you concerned that LGBT plus healthcare is still seen as a sort of second-class issue?
I'm still concerned that the NHS repeatedly churns out policy documents, action plans that ignore us completely. You know, time after time, you see women's health plan, and we don't get a mention in it anywhere. I think that it's right. I mean, people thought, okay, we've been through all of this, the NHS will understand. Well, no, they don't, and they don't particularly for. And they understand HIV because they understand that that's what, you know, there's some medicine you can deal with that. But the rest of our care and health, they don't. Particularly, I would say, for lesbians. I mean, I still think, I know that there are lesbian women who will not go for smear tests because of the experiences that they have had. And when you say to them, you know, educated women, look, this is really dangerous. Yeah, I know, but I'm not being treated like that. I mean, I'm a patron of opening doors. We've done tremendous work in opening doors to raise the visibility of older people, older LGBT people. But the really basic, the basic stuff which does not happen in the NHS is to me constantly staggering. The number of the number of lesbians who go along with their wives and perhaps think I had to have a T-shirt made that says "I'm not her sister." You know, I mean, it is really fundamental blindness to our existence, even in disciplines and areas of medicine where it really should be integral to it. I mean, I have high hopes. Leslie Reagan, who is in charge of the women's health strategy, I have talked to a lot. We're not there because we're not featured very heavily to begin with, largely because that is based around reproductive health, and frankly, when it comes to reproduction, gay people are second class for as far as the NHS is concerned for the moment. But I do think, unless and until we get, great, they've got a rainbow badge in the NHS, but it's high time that they started to live up to it by really truly putting themselves in our shoes and understanding what it is like to walk into a healthcare setting and be met with, at best, incomprehension, because that's all too often what's happening to us. And it's not as though we haven't told them that there are report after report after report sitting on people's shelves about LGBT people's experiences of healthcare. It's all there. It's just never been acted on, either by the NHS, nor actually, for that matter, by the Royal Colleges and the professional bodies. We're never, ever a priority for anybody.
And just to pick up on what Liz says, I think that there's a lot of evidence that there is clear detriment to LGBTQ plus people's health as a result of finding it difficult to access that care, or trying to access it and finding, either experiencing homophobia, biphobia, transphobia, or just finding things that are set up in a way that is so deeply presumptive that you are a heterosexual person or a cisgender person or whatever it may be, that it doesn't feel accessible in the way that it does to others. And that's why we're seeing, for example, fewer LGBTQ plus people going for key screenings, for example, that might be able to save their lives. LGBTQ plus people who are pregnant, less likely to access the things that help them have that healthy pregnancy. You see it all the way across healthcare, and it causes huge inequalities in LGBTQ plus health. It's a really big concern, and I think that people are conscious of it, but it tends not to be up there at the top of the priority list on many occasions when people are thinking about how to design services, because often they will design for the majority and hope everybody else can fit in. But certainly, I've heard many stories that are very distressing about how both staff and patients have experienced prejudice and discrimination, and just services that don't fit their needs within the NHS.
I think from my perspective, I engaged from 2008 with NHS to try and change policy around transgender healthcare, so the transition-related steps. And it's lovely people, very well-meaning, and then they change, and then 4 years later you're starting the conversations again, and then the third time round in 2015 I kind of stepped off the bandwagon, saying there's a kind of corporate memory problem, and in my experience the NHS is not alone in that. But Kay, are there any lessons that we can learn from the past in terms of how to effect change, positive change, without having to rely on a really nasty epidemic?
That is a great question. I mean, speaking from a historical perspective, what it took last time was people having protests, ZAP actions, they called them. This is, when people would get together, a group of activists would get together and go into the foyer of a medical clinic or a hospital or something, or health ministry, and hold die-ins, or this is something that we saw all through the AIDS epidemic as well, obviously, and it really did take a mammoth effort to effect change. I would like to. I think that the what you've just said, Helen, and what Layla was talking about is really right. I mean, there are a lot of really great people, in the NHS. I think one of the kind of, you know, the elephant in the room here is probably funding for one thing. I think that there's probably a pretty significant funding issue. I mean, even if there are all these reports sitting on shelves about health outcomes and recommendations and, you know, tailored kind of needs that actually address minority communities, the opportunities for implementing those changes are curtailed by, and it's not that I'm saying that these changes are necessarily going to cost a lot of money. I think the problem is that the energy in order to effect those changes is kind of gobbled up by dealing with a lot of this revolving door that you're talking about, Helen. Changes, cuts here, cuts there, a shift in the management here. And there's a lot of noise that really gets in the way, I think, of what could actually really be quite simple solutions. And I mean, I think Liz is right. You know, these things have been said over and over again. We're looking at decades now where we have, and not just in the UK, I come from Australia, similar things are going on there. You know, there are recommendations that have been made time and time again that actually don't cost a lot of money. But the energy and the focus is being kind of drowned out by, I think, other concerns. So, I mean, I suppose that's not really answering your question in terms of, you know, what people for example, outside the parliamentary system can do. But I think that there's a lot that people within the parliamentary system can do to really refocus this and to stop kind of, treating LGBTQIA plus people like annoying little mosquitoes who keep saying the same thing over and over again. It would be nice if some of these very, very long-standing recommendations were actually implemented.
Layla, I'll come to Liz in a minute. But Layla, what do you see the barriers within the NHS as being to making those effective changes?
Well, I think the mission, of course, of the NHS is to deliver high quality care for all. And by all, that, of course, needs to incorporate LGBTQ plus people. I guess there are a lot of barriers. One of them is knowledge and awareness. I think that, as I said, historically, so many services have been designed on using certain assumptions that are not helpful for LGBTQ plus people, and just moving past those assumptions to be able to understand what would be a good thing to do. We did a bit of research recently and created a health and care LGBTQ plus inclusion framework to help the NHS think about how to better include LGBTQ plus people. And there were 6 pillars. One was fostering more visible LGBTQ plus leadership and confident staff. One was increasing that knowledge base and understanding and demystifying these things. The next was not making that assumption of heterosexuality or everybody being the same gender that they were assigned at birth. The fourth one is being a lot better at collecting and reporting data so that we can actually see what these issues are and track and produce targets to try to drive them forward. The fifth one, as others have said, is listening to patients and service users and people who are using the NHS, people who are engaging in health discussions, and working with more diverse partners to help design, develop, deliver services. Those are the 6 things that really came through in our research, and we now have a little inclusion framework that people can use. I can share it with you in case you have the opportunity to share the link. But these are the things that we find could be really helpful.
If I just may jump in just with one more thing. I mean, coming from the university sector, I think one of the shocking things that I keep hearing from people, and this is not unique to the UK either, but is that, people that I've spoken to, for example, who have studied medicine or nursing at universities in this country, talk about how they did not have any content in their medical degrees or in their nursing degrees on dealing with sexual or gender minorities. There just wasn't any content in their degrees. So I think that kind of starting at that level also of trying to kind of work with trying to kind of train professionals up before they even make it into the NHS, I think is an important part of the strategy as well.
Thanks. Okay, Liz, you've been working in Parliament for more years than you probably care to remember.
Thank you.
I'm trying to be nice to you. For people who don't know, I'm actually Liz's overpaid member of staff. I think how she likes to reference me. But from a political point of view, what barriers do you see that we still need to overcome, and how can we overcome them, do you think?
I think the biggest barrier is that our health needs are different, and that we are a minority group, and therefore we don't count. That's a very basic level. And I think for some people in the current climate, which is being manufactured, we are portrayed as some kind of threat to the majority, and inclusion including us in overall healthcare is a threat to others. That is ludicrous. That is absolutely ludicrous. You know, gay people, LGBT people get the same medical conditions as everybody else, by and large, with one notable exception, which happens to just a very, very few of us. And I think the biggest battle that we have for the foreseeable future, given this right-wing evangelical wave of backlash which is hitting across the world, is to say that in order to have the best public health that we can possibly have, we have to be included, and we have to be included on the same terms as everybody else. Now, I think that most medical practitioners understand that diseases and conditions don't discriminate. But I think that as money becomes tight and tighter, there will be a great deal of pressure on practitioners to exclude us, to see us as being not part of the mainstream. And I think that's the biggest barrier that we have to get. You cannot have a national health service, you cannot have a healthy nation if you exclude minorities from the provision of healthcare. Simple as. And therefore, I think the job is on for us to not be daunted by all the kickbacks that we're getting at the moment, but to stand our ground and say, no, it is important not just for us that we are included, it's important for other people, because once you allow a health service to start to discriminate on a non-clinical basis, then you're on a slippery slope, I think. And so I think the biggest challenge to us at the moment is to keep our resolve, to keep our dignity, to keep our will together in the face of the battering that our community is taking, and some parts of it are given more than others. But to say, no, we are valid as people, our needs are as valid as anybody else's, and we have to continue to battle for equality of treatment.
Okay, thank you very much. Our half hour is up, so I'd like to thank you for watching, and our three speakers, Baroness Liz Barker, Kate Davison and Layla McCay, for some very, very interesting and erudite contributions. Thank you for your time, the three of you, in what I know is a very busy period, LGBT History Month. I know we get pulled all sorts of different ways, and I know at least one of you has got to leap on a train in about 5 minutes' time. So thank you. If you'd like to join the discussion, do follow Chamber on Twitter, or X as it's now called, at Chamber Voice. And you can visit Chamber's website or email chamber at info@chamberuk.com. Thank you, everybody. Thanks for your time.